Welcome everyone and happy Social Work Month. My name is Annette Johns and I'm the Associate Director of Policy and Practice with the Newfoundland and Labrador Association of Social Workers. I have the honor of being the moderator for today's education event, Many Types of Losses, Understanding and Treating the Complexities of Transitional Loss and Loss Through Death. Sessions that focus on a clinical aspect of social work practice always generates a great response, and we have over 530 social workers from across the country tuning in for this webinar. It is truly wonderful when we can come together to celebrate the profession, learn from our social work colleagues, and enhance our knowledge and skills. This webinar is a collaboration between the Newfoundland and Labrador Association of Social Workers and the Canadian Association of Social Workers. The webinar presentation will be approximately 60 minutes with 30 minutes allotted for questions. Please send in your questions throughout the presentation. Only myself and the presenter will see them. All of the housekeeping details you need are included in the housekeeping widget that popped up when you first logged in. I now want to introduce our speaker, Elizabeth Shepherd-Hewitt. Elizabeth is a registered social worker in Newfoundland and Labrador and received both her BSW and her MSW from Memorial University. In her 28 years as a clinician, she has worked within the justice, medical, rehabilitative, medicine, and mental health systems in Toronto, Halifax, Corner Brook, and St. John's, Newfoundland, Labrador. Elizabeth is the past co-chair of the journal Canadian Social Work and the recipient of the NLASW 2019 Pride in the Profession Award. She is a contributing author of a chapter addressing the challenges of differentiating depression and grief with clients in crisis in the upcoming Routledge publication, New Techniques of Grief Therapy, Bereavement, and Beyond. Elizabeth is the owner of Elizabeth Shepherd-Hewitt Counseling and works as a social worker at Terrace Clinic, which is an adult outpatient mental health therapy clinic with Eastern Health in St. John's. You can read more of Elizabeth's bio on the webinar platform, and I'm sure you're anxious to hear things from Elizabeth, so I'm going to turn things over to her to begin the presentation.
Thank you very much, Annette, and to NLASW and CASW for facilitating this webinar today. I'm really happy to be back talking about grief and loss. For those of you who attended the last webinar I hosted about 3 years ago, you'll be happy to know that the content is different today. So you can also access that webinar online if you're interested in seeing it. Last time there were some really excellent questions about non-death loss, so I thought today might be a good time to talk about those issues. I think as clinicians we understand that our clients have lots of layers and that treating them means understanding these complexities. In order to do so, it means asking questions in different ways and knowing what to ask. Michael White spoke a lot about the value of being curious, and my narrative leanings always bring me back to this teaching. We can't assume to understand the client's context. We must always ask if we hope to truly understand. And so, with this curiosity in mind, let's talk about the many types of losses. In today's session, we have a couple of goals. They are to look at death and transitional or non-death grief and loss. We're going to look at the difference between adaptive or normative grief, complicated grief, and depression with some diagnostic guidelines. And we're going to look at some treatment approaches to working with grief and loss. So each of us, social workers too, experience many levels of loss every day. From the losses we experience when their children go off to daycare, loss of relationships, losses through death, each of these events are significant and has the potential to become a depression. While some of these losses might not seem as challenging to us as clinicians, it's really important to understand that these held very great significance for our clients, so we have to be mindful of what they might be. So what is loss? Loss permeates every area of our lives, and it doesn't have to be crippling to be a loss, but transitions in of themselves simply are. It just means that something of value has been taken away. Now, most of us tend to associate loss with the finality of death, but there are other challenging losses that can impact our mood and our ability to cope. Transitional or non-death losses account for much of the emotional instability our clients encounter in their day-to-day lives, and that's why they show up in our offices. So how is loss different from grief? Well, although a lot of us might use the words interchangeably, loss might be best described as the absence of something valuable, whereas grief is the reaction to this absence, the normal emotional process of reacting to this loss. The way we experience grief can change as well as the person adapts to this loss. There are a number of different phases of grief, and I'd like to talk to you first about the first part, which is acute grief. Now, acute grief occurs in the early period after loss, and it's also really dominant for the person experiencing it. You might see strong feelings of yearning, sorrow, and longing, and there's usually insistent thoughts and painful memories that are present, and the client's activities are really focused on doing or avoiding things to cope with this loss while feeling tremendous emotional upheaval. So you might have a client who maybe lost somebody in high school and that class is graduating. They might avoid going to that school around time of graduation because it's too triggering for them, that kind of thing. Now, integrated grief is what we're looking for. And that is the lasting form of grief in which thoughts, feelings, and behaviors related to loss are integrated into the person's ongoing life. And in this stage, loss is a part of life without dominating life. So for a client that's experiencing integrated grief, they may have lost a parent, for example, and they're not completely focused on the grief. So they might be a mom, they might be a friend, they might be a social worker who has lost their mom, versus I lost my mom, oh yes, and I'm also a social worker and a mother and a runner and all those other parts. It doesn't become the main focus of who they are as a person. So although the process of grief is individual, and on average a typical course of bereavement might last about 1 to 2 years, with some intermittent symptoms throughout the lifespan. So there may be periods of time when the client gets triggered around birthdays, anniversaries of the death, and even though they're coping well, there may be some certain times that are more challenging to manage. We each grieve in a way that is personally meaningful to us, and it doesn't have to meet societal expectations. All that matters is that it works for us, and it doesn't hurt others. The challenge for many people that are experiencing grief, however, is that we all have some personal connection to it, and we all feel like we know the best way to do it, rightly or wrongly. And so sometimes we can put that onus on the people in our lives and our clients, and sort of second guess that the way that they're grieving is beneficial. So what's important for our clients and the people in our lives going through grief to remember is that if it's working for them and they are moving through it, then that's really all that matters. However, if a client or people in your life who are experiencing grief feel stuck, that's the point when they have to think about getting some help. This feeling of stuckness is what we're usually referring to as complicated grief. And that occurs when something interferes with the learning that is the core process of healing. And that's the going from the acute stage to the integrated stage. That doesn't naturally happen. And this result is the feeling of being stuck in acute care, acute loss. So complicated grief is a term that a lot of people might use incorrectly, and I thought it would be important to talk about that as a slide here, since I think there can be many variables when you're talking about death. And a lot of times people say, well, it's a complicated grief because they have to deal with a lot of issues along with losing the person. Or the situation that has changed. But complicated grief is a clinical diagnosis that comes with DSM-5, and there's a lot of very specific variables. It doesn't have anything to do with if there is an addiction or a relationship issue or anything like that along with the grief, although that's oftentimes how people use it. So it's just something to think about as you use that term yourself. Let's talk about what those actual diagnostic features are. And so the DSM-5 identifies complicated grief as having the following characteristics. First of all, bereavement for at least 6 months. Secondly, marked and persistent separation distress with intense feelings of loneliness, yearning, or preoccupation with the person who has died. Significant impairment in social, occupational, or family functioning. All those things have to be present. And then this slide is a little bit busy, so I apologize for that. But basically what the DSM-5 says is there have to be 5 of 9 symptoms that are written here on the page. And they have to be present daily and to a disabling degree. So some of these ones might include diminished sense of self, difficulty accepting the loss intellectually and emotionally, avoidance of reminders of the reality of loss, inability to trust others or to feel that others understand, bitterness or anger over death, difficulty moving on, making new friends, and developing new interests, numbness or inability to feel, sensing that life or the future has no purpose or meaning, and finally, feeling stunned, dazed, or shocked by the death. Now, keeping in mind that the person has to have been feeling this for at least 6 months. So at the 6-month period, if they're still experiencing all those things, then it looks like they most likely are experiencing a complicated grief. I know this is an awful lot to take in, so I thought a comparative chart might be useful. So in the integrated stage of grief, what we're looking for is an acknowledgement of the reality of death. If your client can't accept the death and might avoid reminders of loss, then that is an indicator that it might be a complicated loss. If your client is able to retain access to bittersweet emotions, such as, a funny story about their loved one who passed, then that's what we want. We want integrated loss. However, complicated might be a client who really is so stuck in the pain of loss that they just can't get into those funny stories or anything positive. They're really stuck in pain. In integrated loss, we see that the client can revise how they remember the deceased and the bond that they shared, whereas complicated, that might not be possible. They're really stuck in those relationship and separation issues. In integrated, we see the development of a narrative of loss and the ability to redefine life goals and roles, whereas in complicated, the individual might be fixated on the story of death and self-blame. I wanted to include some information about clinical depression because, of course, complicated grief and depression tend to go pretty closely hand in hand sometimes. So it's important to also understand what depression is. Now, major depressive disorder, MDD, can also simply be known as depression. It is a mental disorder, and that's characterized by at least 2 weeks of low mood that is present across most situations. It's often accompanied by low self-esteem. It tends to be very cognitively based, and that's something to watch for. There's also a loss of interest in normally enjoyed activities, and you'll see low energy and pain without a clear cause. So because a lot of these look very similar to grief, it's important to tell which is a depression and which is a complicated grief, or actually just an integrated grief. So the thing I also want to illustrate is just because something is integrated grief doesn't mean it's not challenging for the client. It's still very painful. There's still a lot of emotion. It's just that they're integrating the loss into their daily life. Okay? So if we look at this chart here, the clinical indicators of grief, you might see that some of these things look very similar to the other column with depression. There may be very similar characteristics, such as isolation. You see in both columns, but the reason that they're isolating is different, and that is the important part. At first blush, when you hear a client say, "I'm not going out, I'm doing these things," you have to ask, why are you not doing that? And that can tell you the difference between if it's grief-related or depression, and that's really, really important to remember. So, for example, with grief, the person may isolate, but they might still feel really emotionally connected to friends and family that they are around. Whereas in depression, they might isolate but feel like an outcast or feel alienated or unsupported by people around them. So that's important to know. There's that cognitive part. In grief, you notice that people will have a hope that the grief will end or get better someday. Whereas in depression, oftentimes there's a real sense of hopelessness that this will never end. As I mentioned earlier, depression tends to be very cognitively based. So you'll notice in the next bullet there that there's some low self-esteem and self-loathing present in depression. And that doesn't seem to be obvious in the clinical indicators of grief. Guilt can be present in both, but with grief you might see that the client might be feeling like they let down the person who died, where the guilt in depression seems to be surrounding feelings of being worthless or useless to others. You might notice on this next screen that there's a loss of pleasure doing things in both columns. However, in grief, it might be because it reminds them of the person that has passed. So maybe they went to bingo every Monday night with their mom, and now suddenly they don't want to go to bingo. Well, it might just be because they're missing their mom, and it really reminds them of their mom, and that's understandable. Whereas in depression, we call this anhedonia, which means that you don't want to do anything. And it's not related to the loss, it's just related to the illness. So if you have a client that says they don't want to go to bingo anymore, check to see why. You might also notice thoughts of not wanting to be alive in both columns. And again, it's about understanding why are they present. For grief, it may be that the person only wants to die because they want to be with the loved one. And if that loved one hadn't died, they wouldn't feel that way. So it's about joining them versus not being alive. And in depression, there may be chronic thoughts of not wanting to be alive, period. You notice under grief that they may find some comfort in being with friends and family, whereas that's often not present for depression. They're generally inconsolable. As well, you'll see ruminating is in both columns. But with grief, that ruminating might be related to the death. For example, if I'd only made him go to the doctor or that kind of thing. Whereas you'll see the cognitive piece in depression, they might be ruminating about feelings of being a bad person, a burden to others, or feeling that nothing good happens in the world. So a lot of times I think we think about complicated grief as being used to describe death. However, in preparing for this webinar, I read about 1 million articles, and I'm not kidding, and I read some really interesting ones about complicated grief as they relate to non-death loss, which I thought was quite interesting. In 2011, Dr. Kathy Shear, who is with the social work department over at Columbia University, and herself a pretty huge authority in complicated grief, she published a really interesting paper with some other researchers. And she looked at complicated grief in relation to the fallout from Hurricane Katrina. It was really interesting if anyone's looking for it. And what they said was that complicated grief can be related to other losses other than death, and that non-death grief might make up a large portion of grief after a natural disaster. So I thought that was really interesting, especially as we're working with clients that may have non-death losses and they seem to be stuck in them. It's very possible for it to be complicated grief. So let's talk about some of these non-death losses that our clients may experience. So again, in preparing this, I think I could have talked for about an hour about any of these things. So what I thought I would do is just kind of hit the highlights for most of the big ones that we would often see in our practice. And these are loss of connection, loss through job change, loss through chronic illness, and loss through addiction. So loss of connection. Well, the fact of the matter is that humans are social creatures, and interpersonal connection is a really vital part of all of our existence. And so when we lose these connections, it can be really shattering to us. There's a lot of research that talks about the impact of loss of custody, and it all says the same thing, that significant trauma results from changes, regardless of what the circumstances are. I looked at a couple of really interesting Canadian research articles. One was by some researchers at Manitoba, Walweiler, in 2018. They looked at the impact of custody through Child Protective Services of children between the years of 1992 and 2015. And what they did is they looked to see how that impacted mothers and their mental health. The interesting thing was is they compared them to the mother's biological sister and other mothers who were also involved with CPS who did not lose custody. And what they found was that there were significantly higher rates of suicide attempts and completions in comparison with these other groups. So obviously we all knew it would have an impact, but it certainly has a pretty significant impact on these women. There was another Canadian study that was done in Toronto back in 2015, and what they did was they looked at the impact that apprehension had on 19 substance-using women who lived in Toronto. And these women talked about PTSD and mental health conditions that came as a result of the apprehension and some increased drug use. Now, the study doesn't talk about what the variables were that led to the apprehension, but it does say that this was the fallout for these women. And these women said pretty much that the reason that they were still alive is because they had hoped that they might reconnect with their children. But that was pretty much it. The flip side is true as well. This loss of connection affects the children who lose connection with their families as well, even though we all know that apprehension is in the best interest of our children, and we want to keep them safe, and it's not a terrible thing to go into custody, but I think there are implications for them as well that we really must pay attention to. And youth in foster care experience ambiguous loss of their parents, their grandparents, their siblings, their friends, their schools, their communities, no matter where, but they are experiencing tremendous loss. The research talks about this loss of siblings as being the most challenging, and certainly for any of us who've worked with children who've experienced care as adults or children, we've noticed that, a lot of times the children tend to work together if there's some issue with the parenting, and they might support each other. There might be some parentification. And so when sibling groups are broken up, it's a huge loss to them. Some of the other losses, of course, include those psychosocial losses, the loss of independence and self and community. But the one thing that they talk about is how important it is just to validate that. So if you look at connection, it's about thinking to yourself, okay, I'm working with a person who is, if you're working with children, this is somebody that's gone through that experience. Or you might be working with an adult that has gone through foster care. These are variables to think about in terms of as they relate to other issues that you might be working on that might just not have been happening. They might not have gotten that validation. And so disenfranchised grief is something that we really need to pay attention to, and that just means grief that hasn't been acknowledged. Something that we all work on, I think, predominantly in no matter what area of social work we practice in, is the loss of those romantic relationships because they seem to be really, really disruptive. Another interesting Canadian study, I'm trying to hit all the Canadian stats today, there was a really cool study that happened at a University of New Brunswick in 2018, and they did a really cutting-edge study where they accessed social media to look at some of the results. They wanted to sort of figure out how resiliency, optimism, and grit, self-esteem impact with breakups and in terms of who's going to get depressed and who's going to recover faster. So they had 886 individuals who were in their late teens and early 20s. They went through Twitter, Facebook, Kijiji, and some crowdsourcing through Amazon. And they had two groups, and one who had a breakup within the last 3 months and another who had experienced a breakup a little less recently. So they did some really interesting surveys, and I thought I would include what they were for those of us who like to use surveys. Some of these I'm familiar with and I use myself, but not all of them. So the Rosenberg Self-Esteem Questionnaire I have used, and I find that quite user-friendly. There's the short grit scale that looked at sort of that determined variable. The life orientation test, which measured optimism versus pessimism. The BDI to look at depression, and the ruminative responsive scale. So everybody in the survey were measured on those scales. And the results showed that individuals who reported low self-esteem and grit were already experiencing a lot of distress, and this breakup didn't really appear to contribute to any depression. In comparison, the individuals who reported high self-esteem and grit, they had a lot more difficulty. And they still did better than the other group, but they really struggled with it. And so they talked a little bit about why they did, and so they thought that maybe one of the variables was they took a little bit of a hit to their self-esteem and their identity as somebody that was worthy of having a good, healthy relationship and that kind of thing. But overall, the results were the group that had higher premorbid self-esteem, optimism, and grit, they experienced lower levels of depression symptoms and rumination overall in the 3 months following a breakup. I think that's important for us to think about, because when we see our clients in our office and they're not doing well, it's about targeting those areas because they seem to be really predictive of resilience. So we can look at that self-esteem, we can look at that grit, and we can look at those things right here, the optimism, self-esteem, and grit as being determining variables in terms of resilience in our clients. So that's how we can help them knowing those things. Now, there's been a lot of research that have talked about, which groups fare better with breakups and which groups have less loss. And some people have said that women have a higher level of breakup distress, but there was a recent meta-analysis that basically said there's really not much difference. And I think that what we're looking at is a changing of the times when, generally speaking, women seem to have an easier time getting that psychological help. And they are a little bit more accepting. And we're looking at a societal shift. 20 years ago and even earlier than that, clients that were male were less likely to go seek help, and they were less likely to talk about feelings. But we're seeing a real change, which is wonderful, because what's happening is we're seeing men be able to advocate for themselves and recognize that they can still be a man and they can still have a normal range of emotions that a lot of the times men weren't permitted to have, which was absolutely ridiculous. But now they're realizing, I get to feel stuff too, and I get to talk about it. So, of course, men are having just as much distress as women are when they lose significant relationships. So the research also talks about some of the things that help in terms of recovering from the end of a relationship. And they are, again, pretty universal across all the demographics. A clear understanding for the reason of a breakup. Now, many of the clients I get in my office, they really get stuck on that. They don't understand what happened. They really struggle with letting go of that. And so it's that inability to understand that really leads to that rumination. And when we ruminate and we can't get out of that cycle, that leads to an increased risk of depression. So we have to watch that in our clients for sure. Another variable is the lack of personal responsibility for the end of the relationship. And so clients who initiate a breakup can generally face greater challenges in moderating the guilt and shame that might come with being the person who has to leave. The third one is being in a relationship versus staying single. Now, clients who are distracted by a new relationship, they receive that external validation that they are worthy to be a partner and of the love and the attention that they get, and they often struggle less. Loss of relationships, of course, can really impact our ability to move forward, and having strong relationships with others is very helpful in terms of moving. People who have strong social supports are less inclined to socially isolate, and they're encouraged to seek help, and should their low mood really become an issue. So the people around them are watching them, and they're supporting them and making sure that they're okay. Now, emotional connection is bigger than just the people in our lives. Certainly, it can also include our pets. And so when we have a loss that's related to losing an animal that's a dear part of our family, it can be very challenging as well. Unfortunately, sometimes we as clinicians might not recognize that this can be a significant part in terms of the grieving and loss. And the people around us might say something foolish like, oh, it's just an animal, you're going to have to get over that. So, but we have to be mindful that it's a lot bigger than that. So some really interesting articles that I read about this I thought I wanted to share today. So variables impacting the depth of loss in the literature include the degree of effective attachment to the pet, so how close you were to your animal, how sudden the death was, and whether you lived alone or not. So if it was just you and your dog died, then the house feels a lot emptier for sure. Now, interestingly, the type of pet didn't seem to make any difference. So if it was a reptile or a dog or a cat, it didn't seem to make a difference, which was interesting. And how long it had been since the animal had died wasn't a variable. And it wasn't even a variable how long you'd had the pet, which was surprising as well. Now, we have the age-old battle of if you're a dog person or a cat person. And they did a couple of studies to see if there was any difference in bereavement amongst dog owners and cat owners, but there was absolutely no difference in the research, which was interesting. The other thing that they talked about was that pet owners who euthanize their pets, they experience lower grief severity than those whose pets died a natural death, which I was surprised about as well. Yeah. Lastly, there was an interesting study that was done with college students, and what they did was they compared the loss of a pet and the loss of a person within the last 2 years. They wanted to see if there was a difference in how people grieved, and the results showed that the death of a person was higher, but that really they were pretty close. And what the authors said was the real variable that was the determinant was how close you were. So if you were somebody that had your dog who slept on your bed every day for 15 years, you were super close, you might have a bigger loss with that versus an aunt that you didn't know that well or a distant cousin. So closeness really appears to be the variable. So let's talk a little about employment. So all of those emotional losses we can see can follow us into employment losses as well, because of course, we feel emotional loss no matter where we are. And in this day and age, we're noticing an awful lot of changes in the workplace. People are moving from offices to cubicles and pods and new sites. There's changes in the way departments and organizations are managed. There's changes in staffing ratios and new personnel and changes in responsibility. It's endless. And so each of these are losses. With pressure to do more for less, many clients, and social workers too, are enduring significant loss as it relates to daily life. The challenge is we may not be acknowledging it as loss, but it's really important that we do so. Now, Dr. William Warden, back in 91, he talked about some 4 tasks of mourning, and I thought that would be useful to look at with regards to the context of job loss. And some of these tasks really are things that we should work through in our daily life anyway, but maybe we're not doing it the way we need to. So it's worth looking at. Task number 1 is accepting the reality of the loss. Now, as I was preparing for this, I couldn't help but think about my own job losses in the past. We had a major shakeup here 3 years ago in terms of at Eastern Health. When I had to, with regards to some reorganization, I moved to a new work site, and I had to walk away from relationships that I'd built for 10 years and people that I really genuinely cared for. It was a tremendous loss. Even though it was part of the process and I accepted it, I still went through that. And so accepting the reality of the loss is a huge part for each of us in this situation. Task 2 involves reaching the pain and other feelings of grief. And that task really means to talk about how we're feeling, to recognize it, not to push it aside. We have to process it, and our clients do as well. Task number 3 involves making the need changes for the new work situation. And that might mean figuring out what the new processes are, figuring out who you're working with, finding your new office, that kind of thing. And finally, developing a new group identity and making new bonds. That might mean figuring out where you fit within this new group. where your value is, what you bring to the table. And so when our clients come in talking about changes in employment, you might want to help them work on those 4 tasks. You might want to help them validate that these are huge issues and that taking them seriously is really important in terms of moving towards wellness. For those people interested in some more information about that, I was showing Annette the book earlier, but I found it at the Waterford Hospital for those of you living here in St. John's. It's called Coping with Workplace Change. I'm holding the book up for Annette. It's a lovely little book, and it's really practical. It talks about adjusting issues for survivors of layoff and other organizational change with some really nice adaptive suggestions. So always nice to have a practical book. Now, with regards to other losses in employment, a lot of us don't tend to think about retirement as being an area that there would be loss, but really that's the way it is. And so when we hear clients say that they have retirement coming up, we don't want to just assume that this is a positive thing. We want to check into that, and we want to see where the client is, because there can be a lot of hidden losses that, we might not automatically think about. And so some clients might not have balanced lives, and so employment might be a real central part of who they are and their identity. And leaving work for these clients might mean separating from who they are. And as well, sometimes people have to have a health-related retirement because they just are not physically able to do the work that they want to do and love to do. And this could be a huge adjustment in of itself, impacting things like self-esteem. As well, many clients struggle with social isolation, and this can be a really significant threat for those who don't have a big friend circle outside of the office. There was a study that talked about women having a more difficult transition because they can lose the emotional support they get at work. And certainly I've spent a lot of my career working in hospitals and watching, the floor nurses go down as a big group to the cafeteria lunchtime and break time and all the laughter that ensued from being together. So you can appreciate if any of them were to retire, they would lose 20 of their closest friends. So it's a huge transition for sure. There can also be financial security issues that come from retirement because many of our clients, they might not have the retirement income that they wanted to have, that they need to have. And that worry about how do they support their families and how do they pay their bills is quite significant. As well, from the moment that we enter the workforce, we are really geared towards thinking about retirement, and we have all these wonderful fantasies about what retirement was going to be like. 6 months in the south of France and going to paint on in Paris and all kinds of beautiful things that we imagine ourselves doing. And then when we do the money crunching, we may realize that's not going to happen like that. So there's a lot of loss associated with what we anticipated and what we can really realistically have. Recognizing the impact of job loss on our clients is very important as it really connects significantly to their emotional well-being. So whether your client is personally experiencing the job loss or change, or it's the parent, the partner, or the child of the individual, everybody in that system can feel the impact. So in sum, always check, never assume. Chronic illness is something that we see a lot of our clients also experience loss with. And they can experience lots of different types of losses. It could be illness, it can be disability, it can be lots of different things. And the big piece for a lot of people is just accepting that they just can't do the things that they love because of these physical limitations. Tremendous loss. A key component of chronic illness adaptation is acceptance. And adapting to chronic illness really often means that the client must come to terms with the fact that not only will that health issue not resolve, it might actually get worse. And integrating this knowledge into daily life often results in many more losses. I included this picture of this lovely soul here hooked up to a dialysis unit. And I worked for many years in renal dialysis here in Newfoundland and also in Halifax. And so this is a great illustration of adaptation because there's nothing for people with renal dialysis issues that they might have to be hooked up to a dialysis machine 3 times a week, 4 times a day. 3 times a week, 4 hours per day. And, talk about adaptation there. And then you get home and you're exhausted. So really adapting to chronic illness can make a huge difference in terms of quality of life. The other thing with chronic illness and loss is just the changes that come from the daily living. And this could be as simple as a runner being told that she can't run again because she might have osteoarthritis in her knees or her hips, a woodworker developing rheumatoid arthritis in her hands, a singer who has some vocal cord issues, and children being diagnosed with peanut allergies and other food allergies. These are huge losses, and we have to be mindful of them in our clients when they come in and talk about them. So I think sometimes what happens is they can say it quite casually, like they don't really have an issue, but they have this going on. And it's about us following up on that and making sure we really have a good understanding. So clients experiencing difficulty adjusting to these losses might express them in response to their own diagnoses, those of their children. It may be that their parents or other family members are experiencing this chronic illness, and their friends and coworkers. And again, if we look at systems theory, we see that, if one person in the system is experiencing this, everybody is. And so we have to take those into consideration as well in terms of our treatment. So adaptation to the losses associated with chronic illness in people around us can create significant burden. And we might see our clients experiencing physical, emotional, and social demand and tremendous burnout for those that are providing the care. Our clients might face a host of losses, including loss of independence, loss of productivity, self-esteem, loss of control, and loss of dreams for the future. And they may, of course, impact the ability to work, continue with those much-loved activities, and interact with family and friends in the preferred ways. So it really is important to be mindful of the impact of chronic illness when we work with our clients. It's not uncommon for clients presenting with a depression, seeking depression therapy, to also be impacted by hidden illnesses like fibromyalgia, chronic pain, or diabetes, or for a person to come to see you for anxiety, and they might have underlying stressors such as a child with food allergy that causes them great worry. We need to kind of look under the hood when people come in to find out if there's some other issues that are impacting that issue for them. And taking these needs into consideration really ensures that we meet the holistic treatment needs of our clients. Now, the last section that I want to talk about with regards to loss before we move into treatment is addiction. And this presentation actually originated from the addiction community here in St. John's wanting to have a little bit of information around loss. So thank you very much to my coworkers in addictions here at Eastern Health. As I prepared for this, I just became so much more aware of the tremendous loss that's happening for the people dealing with this. So my hat's off to you, addiction workers. You're doing some really fantastic work. I wanted to talk about these losses because there's so much involved with individuals coping with substance use disorder and their loved ones. And we know that there is a really strong relationship between traumatic loss and the development of a substance use disorder, as well as the losses endured as a result of the development of an addiction. So loss alone is not a determinant for addiction, nor do certain losses lead to substance abuse. That's really important to say up front. Now, going all the way back to 1979, Sholnick reported that people who experienced addiction and kept returning to drug use appeared to have encountered deeper losses in life, and they just couldn't talk about them. And while we can't definitively state what causes one person who is experiencing loss to develop a substance use disorder, there can be a lot of significant variables. So these are not like primary determinants, but these are things to keep in mind with your populations. Children who lose one or more parents between the ages of 6 to 18 years appear to have a greater risk of developing a substance use problem. We also know that the likelihood of developing a substance use disorder is nearly doubled among young adults who experience multiple deaths in a short period. And thirdly, women in substance use treatment often have a history of childhood, physical, emotional, or sexual abuse. There are some additional variables that can impact the development of a substance use disorder, and they might include lack of additional coping strategies, social acceptance of substance use as a coping strategy, difficulty identifying and understanding and communicating personal needs, difficulty accessing emotional supports, and an inability to assimilate loss into a system of meaning. Now, individual grief and loss associated with substance use has been connected with the early life losses that I just spoke about, but also losses that occurred while abusing the substances and losses encountered while entering recovery. So those are things that we don't tend to think about. So I thought that was worth exploring right now. Loss of relationships, jobs, and financial losses, physical illnesses with memory and related illness, and psychological losses, including self-respect and self-confidence, can result from substance use disorder. So Friedman in 1994 stated that the alcoholic who is actively drinking is involved in a perpetual state of grief, a response to the many losses that are experienced over the years of uncontrolled drinking. Very significant statement. Individuals with substance use disorder might also be excluded from really important moments, such as funerals, because the other members of the family might not want them around. It might be uncomfortable for them. And sometimes in the literature I saw that the death scene might be avoided to prevent confrontation with authorities. I read an article that talked about with heroin use, when people would OD, sometimes it wouldn't be safe, so they might call the police and take off, so they weren't able to be there with their loved one in those final moments, which was quite traumatic for them. Those who experience this type of grief may experience confusion about how to express grief once they are clean and sober. And as well, because of the multiple experiences with death, it could be viewed as a part of life, and that there was some sort of general acceptance of their own mortality. There was a quote, "I lived longer than I expected. I thought I would die before my 40th birthday." And I thought that was just so sobering. So, because dependency on substances is often in response to an inability to fulfill needs, abstinence can mean a loss of coping strategies. This is what happens when people go into treatment. So the way that they've been coping with these traumatic issues or these losses, early parts of their life or different stages, suddenly their coping strategy is gone. So they're trying to get clean and sober, and all of a sudden the resurgence of pain from all these unresolved issues hits them between the eyes, and it's exceptionally difficult. McGovern and Peterson said that really awareness of loss could be higher upon completing treatment because, of course, they weren't able to use those masking strategies that alcohol and other substances brought. As well, with recovery, the individual also can lose membership in that addiction community. And they're separated by friends and family who use substances. They can't be around them because they really jeopardize their sobriety. And social activities and hobbies might be lost because maybe those things occur in situations that are not safe to their sobriety, like in pool halls and dart leagues that are held in bars. They can't do that anymore. So in addition to the individual's losses going through, there's also significant loss experienced by the family of the loved one experiencing a substance use disorder. And grief and loss experienced by the family can be with regards to loss of hopes and dreams for the person who's using, loss of connection. They might lose the loved one. They might lose their child. They might lose their partner and the connection that they have with them, and those relationships may change. There's a loss of quality of life as they attend to the person with the disorder. They might have to quit their job to care for the loved ones. There may be financial strain for rehab, and they may be constantly rescuing, which it really significantly impacts their quality of life. As well, many family members might feel that loss of support because they don't really want to talk about what they're dealing with. They might feel stigma from people around them, and they might feel very unsupported by family and friends, and that they're just not understood. There's loss of stability as they deal with roller coastering emotions associated with fear and worry about their loved one's addictions and demands. And of course, we know about the connection between emotional and physical well-being, and so there can be significant personal health issues with anxiety, worry, stress, depression, and physical health impact. Parents of adult children with substance use disorder often struggle with living with the blame and shame. They feel humiliation and guilt and coping with the disruption of the family and relationship with others. And many parents struggle with chronic sorrow and hopelessness in addition to the loss of what could have been. So now, while any death can be devastating, there also appear to be some additional considerations for death related to substance abuse. There was a lovely little quote that I thought summed it up nicely, and it was that death through addiction is an abrupt loss by non-natural causes that is loaded with social moral stigmas, secrecy, shame, and denial, in addition to producing strong feelings of anger, hopelessness, and guilt. So as if dealing with the loss wasn't significant enough, it just becomes so much more colored. So we just talked about a lot of these losses. And, what do? We understand what those losses are, but how do we help them? And we can really start by having a good understanding of what the loss is that they're experiencing from within something that I think we all probably learned how to do when we got our first degree in social work, which is the biopsychosocial perspective. Now, as a quick refresher, back in 1977, George Engel came up with this model, and he said that there were 3 variables that were the best ways to completely understand health and its issues, and that was biological, psychological, and social variables. So if we use this model as a framework and we make it loss-informed, that can really help us in figuring that out for our clients. So what are the biological variables with regards to loss? Well, as you're assessing your client, you might think about asking them things like, do they have an appetite? Are they eating? Are they getting restful sleep at night? Are there any other illnesses that are impacting their ability to cope with this loss? Do they have a thyroid issue? Because changes in eating and sleeping are really normal after significant life disruption and loss. Sleep hygiene is essential, so we want to monitor this and encourage regular eating and sleeping patterns, and notice if appetite changes occur, if they can't fall asleep or stay asleep, or if they wake early. As well, a lot of my clients will come in and they'll say that they're napping during the day because they're not sleeping well, and that's going to really impact good quality REM sleep, so you want to help them work through that. Continued issues could indicate the development of a depression, and illnesses such as diabetes are significantly impacted by changes in eating and sleeping, and illness instability can really impact negatively mood. Chronic pain might be impacting the ability to sleep, and thyroid issues can also mimic a depression. So if we're looking at all these biological issues, they might be significantly impacting the way that the person is processing loss. Any significant biological changes should be redirected to their GP or any psychiatrist that might be involved. What are the psychological variables? Well, how is the person processing the emotion? Are they experiencing shock, denial, anger, or sadness? Are they processing, or do they appear stuck? Are they experiencing cognitive impact from the loss, such as low self-esteem or self-loathing? Is there any hopelessness? And if there's guilt, why? Are they ruminating? And if so, what is it about? Do they want to die? Exploring these variables can help you to determine if the client is in pain but is processing integrated grief versus complicated, or if there is a depression. The social variables might be very important for us to understand as well. So, for example, is the client isolating since the loss, and why? Do they find comfort in being with friends, or are they inconsolable? Is there a loss of pleasure in doing things with others, or anything at all? And that would be, say, an anhedonia. It's important to explore why these behaviors are occurring. Isolating because they feel alienated from others would indicate a depression, and that's different from isolating but maintaining emotional connection to others, which is a grief. Inconsolable indicates depression, as does the anhedonia. So major depression can occur within the context of a bereavement in the same way it can occur following any other significant life event, a loss of a pet, job, relationship, or traumatic event. You can grieve and also be depressed. That's really important to keep in mind. As well, breakups are often linked to a number of serious outcomes, including suicidal ideation and attempts, clinical depression, anxiety, irritability, trouble concentrating, and substance use. Always screen carefully for indicators that your client's loss has shifted into something requiring medical intervention. So we've assessed our clients using the BPS approach that is now loss-informed and discovered that the client is experiencing multi-level losses. What do we do now? Well, we go back to Maslow. And Maslow's hierarchy of needs is really relevant in addressing treatment because he really reminds us that base level needs must be ensured before higher level goals can be attained. So a client struggling with financial losses jeopardizing their shelter and food cannot focus on how they feel the loss of employment affects self-esteem. A client experiencing depression is more focused on inability to sleep, eat, or a lack of desire to be alive. With these base level needs impacted, clients have difficulty striving to meet any other goals of self-actualization in the shadow of loss, and any loss can become a depression with a risk to safety. Depending on what the assessment is, we first need to start to stabilize with safety. If a depression is determined to be a risk, our goal is to stabilize this. If the client is unsafe because of a substance use disorder, we have to stabilize this. Other losses, while significant and important, must be secondary to those impacting safety. We can still validate the additional losses, but the primary goal must always be keeping your client safe. And the nice thing about this, working with teams, is that we can bring other people in. It is not your sole responsibility to keep that client stable. Work with the GP and other members of the team as necessary. As well, we can enlist support from family and friends through the client as well. Once the client is safe, we can explore the impact of loss. And there are a number of ways we can do that. Building emotional language to start adaptation to loss is key. So you might do something like offer the client a list of emotion words and ask them to find a word that might more accurately describe the feeling. A lot of people have 3 words for emotions, and they are happy, sad, mad. And we want them to have a little bit more variety. So mad might become powerless, betrayed, hurt, any other issues. And each of these words are really important because having the correct label facilitates a greater understanding for the people around them and communicating their needs. Once the client has increased their emotional language, you might want to look at understanding the somatic response to help them build increased awareness of how it impacts their daily coping. Now, many times our emotions become overextended dealing with loss, and we don't have very much resilience to deal with day-to-day issues like being cut off in traffic, having a disagreement with a coworker, etc. And so what we want to help our clients do is recognize how we are somatically feeling in order to have a better sense of what these emotions are that are building. So you might ask them, for example, where do you feel the betrayal in your body? How do you first recognize what's going on? What does your body need to release it? And so what we want to do is create a greater awareness so that they can strategize and move forward. We want to educate your clients about non-adaptive strategies and their dangers. A lot of people I know will go out drinking with friends if they have any significant loss, and that's to convince themselves that they're okay. And so the problem with that, of course, is that combination of feeling low with alcohol is a really bad combination that sometimes people may not really recognize because of the social acceptability of that. Alcohol is a depressant, and instead of helping the client feel better, it can make mood plummet. As well, staying out late will mean that seeing other people at their worst, tired, unfiltered, drunk, and this can only highlight the loss. What we want to do instead is encourage your clients to maintain positive social connections with the people that they love who love them back, friends, coworkers, and family. Go out during the day, spending time with people who are positive, optimistic about life, and easy to spend time with. Engage in activities that distract from the loss and give them positive experiences to compete for space in their minds. focus on helping clients value themselves separate from the loss, working on such goals as self-love, resilience, optimism, boundary setting, healthy expectations in all areas of their lives. And you want to give clients permission to be sad but not be trapped by it. This is a little diagram that I draw for most of my clients that are dealing with loss, and you see there's two ovals, one with loss, the other with the other variables of just daily life, friends, jobs, family, activities, and hobbies. And what I encourage people to do is to visit both ovals. Many times people become stuck in one or the other. They may be trapped by the loss and not be able to live their life, or they may be in denial from the loss and stay stuck in the life goals, but that stuff is haunting them and they can't move through it. I encourage people to go back and forth, to zigzag, to pay attention to loss and then go back to life. And they might visit loss again and then go back again. And so in doing so, what we're doing is we're being mindful of the needs of the loss and the validation that this is happening, that this is real, and this is deserving of time and attention. And essentially what happens if we are respectful of loss, the need for loss, visitation, becomes smaller, and it does not dominate. So it's important to recognize that just because you're going through loss doesn't mean we have to hide from it or be afraid of it, but being mindful of the fact that it is real. We also want to assist clients to grieve the loss, but to view it realistically and not idealistically. And a lot of times when we have emotional loss, people might sort of reflect on that and say, oh, it was the perfect relationship. Well, if it was the perfect relationship, it wouldn't have ended. There can be lots of variables, of course, but we can look at things through rose-colored glasses. There are a number of wonderful approaches to grief therapy, and many of them I highlighted in the last webinar that I did, and certainly you can check that out online if you're interested. I would like to also recommend reading anything by Dr. Bob Nehmeyer, and he has published extensively, or you can do one of his workshops. And the chapter of the book that I have coming out is in one of Bob's anthologies, so I highly recommend him. As well, Dr. Kathy Shear at Columbia University that I talked about that study with earlier. She's done a really wonderful, complicated grief treatment program, and it's quite widely acclaimed. And I recently purchased an online manual and video series for a really reasonable price from her. So if you're interested in complicated grief, I'd really highly encourage you to check that out. As well, EMDR therapy is another really useful therapy in treating all types of traumas and loss. I actually got trained in EMDR about 16 months ago, and I've used it with some really great success in combination with some other narrative approaches. And I find it really effective in facilitating that processing that's important for moving through loss. EMDR is considered one of the top 2 therapies for treating trauma, and of course loss and trauma are really closely connected. If you're interested in learning more about EMDR, you can check out their website, emdrcanada.org. There are also some really great opportunities to do group work with any of these client groups that we've talked about today. And here in my community, we have some wonderful groups for individuals impacted by addiction and others for family and friends. Here in St. John's, Newfoundland, we have chronic pain groups and grief groups, and some follow a peer support model, and others are more structured psychoeducational and therapeutic groups. The commonality of group work, of course, can be really empowering for our clients and very rewarding for us as clinicians. So in conclusion, I'd just like to say that, as good clinicians, social workers have always done our best to help our clients through loss and grief. And my hope in presenting all of this information to you today, and I'm sorry if it was fast, is that I've really illustrated how many layers of loss our clients have actually been experiencing. And these might be layers that we wouldn't have actively pursued and looked to understand. I really believe that awareness assists in developing good treatment goals and validating the needs of our clients. And those are things that social workers have been really good at doing for many, many years.
Hey, wonderful. Oh, my goodness. Thank you so much, Elizabeth. Lots of great material, and we've arrived at our question and answer period. So we will try to get to the majority of questions. So we do have, another bit of time. So if you do have a question, get those in, and we'll certainly go through them. So just want to start, Elizabeth. We had a member who, or participant who was wondering if the nature of grief changes based on the type of death, particularly in relation to losing a loved one to suicide.
Ooh, that's a good question. I think that the individual's perception of loss is really shaped by so many different variables. And some of the stuff that they talked about in the literature is the attachment and the closeness. And we see that with any type of relationship, whether it's with a person, whether it's with an animal or whatnot. And so if this was a really close connection to someone and then it was a traumatic loss, absolutely that can have a huge impact on adaptation and the way that you process loss, for sure. And so that's why I think it's really important, if you have a client that's experiencing a traumatic loss like that, to explore all of the different ways that it's affecting them, and really have a look at, those tables that I had in terms of if we're looking at a complicated grief or a depression as well. So you want to really kind of be really micro-exploring how that's impacting your client. But certainly a traumatic loss is always more challenging, but not undoable. It's about just really exploring from the ground up all the different ways that this loss has been impacting the client, for sure.
Mm-hmm. Okay, great. We have another question. Do you have any advice, tips, or resources for individuals who work in a setting where they experience a lot of loss with regards to clients dying?
Well, I think that's the thing, because, vicarious trauma is certainly something that we're talking a lot more now as practitioners. I think that we have to approach loss in our own lives the same way that we would encourage our clients to do them, is to really be reflective of what we need as people in terms of healing. We are expected sometimes to be, superhuman in terms of handling all these things, but we are people. And so being able to express that loss and to go back to those stages of mourning that I talked about with regards to the employment loss, the different tasks that are involved in terms of acknowledging that what we're feeling and moving through the process of healing as what we are being exposed to is really essential. So in terms of how do we do that, I think it starts with what do we need? How is this affecting us at a base level? How is this impacting the way that we see ourselves? How is this impacting the quality of our life? And working to resolve that by having the support of the people that love us, by getting the support of our coworkers, by taking time to heal and having distractions in our lives, by being able to find meaning in the loss that we have. But above all else, I think we have to start by healing ourselves. And if we feel that we're overloaded in an area with a lot of loss, then we have to think about, is this something that's too much for us? Do we need to shift our caseload a little bit? Do we need to have more balance? Because we can only give as much as we have, and when we overgive, then we are the ones that suffer.
Okay, wonderful. Thank you. More of a practical question, and Elizabeth, you mentioned this at the beginning of our webinar in terms of where they can find your webinar that you did previously on grief and loss, and just want to say that's available on the CASW website and on the NLASW website.
Yeah, I know for sure it's on the NLASW website because I've seen it there. I had a harder time finding it on the CASW. It might just be really well hidden, but I know it's much easier to find on the NLASW website.
Yeah. So anyone can go onto our website at www.nlasw.ca, go into our continuing education and past events on our YouTube channel, and you can find all of our webinars.
Yes.
Yep. This one, a question's on more from Newfoundland and Labrador, but in terms of anyone that you know of who practices EMDR, yourself included, and anyone at the Marchant House that train in that as well.
So right now, I know that I did a presentation last Social Work Month at the Health Science on EMDR. And from what I understand, it inspired some of the social workers, which I am so delighted to hear, because if we all got trained in the EMDR, I think it'd be a really, really good thing for all of us and our clients. At present, as far as I know, I am the only person here at Eastern Health, the only social worker that is fully trained in EMDR therapy. I know there's a psychologist, Stacy, over in the West End, who's got the first part. I'm not sure she's got the second part of training done. But I know that there's actually a training event happening in May that a number of social workers I know of are going to. So I don't know if anybody from Lamarchand House is going there. I'm not sure about that, but I would hope. Right now, it's just me.
Okay. Thank you. Okay, another question that we have is, how can we empower clients to move forward in environments where at times the healthcare professionals can feel disempowered by the amount of loss? For example, people moving into long-term care facilities.
Wow, that's a really good question. It's so hard. And I think this gets back to the section we talk about loss and employment. I think when we see so much change, I think we can't help but be impacted by that ourselves. And I shared a little bit of my own journey with loss, and as I was forced to adapt to a changing system, and I felt very disempowered by that loss and very flattened, and I had to really just pay attention to how I was feeling, because if I didn't process that myself, I wouldn't have been able to help anyone else. So it's really, like for me, I can speak to how I coped with that, and I talked about it with anyone who would listen, and maybe some people who weren't really particularly interested in listening, but I talked about it, and a lot of people are feeling the same way, and so being able to talk it out and to vent, and not in an aggressive, nasty way, but as a way to validate each other and to encourage and support each other, recognizing that these are big changes that we're all experiencing, and to heal in the best way that we can. That's the hardest part.
Okay. Someone just had a comment, and I'll just read it out there, Elizabeth. Just want to make a comment that based on the research said they have people fare better when they're in a new relationship versus being single. When they grieve a relationship loss, it makes sense why some may seek experience that the biological need, for example, belongingness,
yes.
Maslow's hierarchy.
Yeah, absolutely,
yeah.
Absolutely. Yeah. And I think that's what it is. We need to pay attention to the things that make sense and the things that ground us, right? For sure, absolutely.
Yeah. Okay, just another question in terms of how do you treat clients with complex trauma who've had many losses?
I think what we need to do is we need to look at we need to start with safety. And again, it goes back to what we were talking about initially. So if you have a client that comes to you and their presenting issue is they have lots of levels of trauma, we have to start with what is causing the most distress first. If we can start with a position of safety, then we can very, very, very carefully open up the layers of trauma. What I've noticed in my practice is that if we are respectful of how trauma has impacted loss, that they seem to heal a little bit more gently. Now, everybody's experience with complex trauma is different, and I'm certainly not trying to say there's one approach, but this is what I've noticed, is that particularly the work that I've done with EMDR and complex trauma, when we start to respectfully address that loss, overall mood seems to shift. And I had a situation within the last couple of weeks with somebody with horrific complex trauma that is now feeling like they're coming out from underneath a deep depression they've had for 12 years. So I think when we work at the base level of trying to be respectful of that loss and work through that layer by layer, good things happen.
Thank you. Not sure if you would have any insight into this, Elizabeth, but a question's been asked in terms of any recommendations around certified end-of-life doula programs that you may have heard of or anything.
No, I'm sorry, I don't, but that's a great question. If anybody else knows about that, feel free to write in.
Write in, and we'll let.
Great question.
Yes, yes. Okay, another question. You were talking about EMDR. How does EMDR help in the treatment of complicated grief?
Well, the thing about EMDR, for anybody that knows anything about it or doesn't, so basically EMDR's claim to fame is that it helps people to process when they get stuck. And so the reason that it works is that when we have traumatic things happen, the emotion from that event sort of protects the incident from being processed. And so with EMDR, we separate the emotion from the event, and then the brain does its natural job of processing the event and putting it away so it doesn't continue to trigger the individual. So when we're talking about complicated grief, that is a period of time that is blocked from being processed. It is frozen, and so the client is unable to move through it. I have used it with success with clients experiencing complicated grief because it facilitates that movement that we want, and so they don't remain stuck in the grief. Now, when I say stuck in the grief, I'm not saying that they magically don't care anymore. It means that they're able to move through into that integrative state of grieving. And that is what we want. The goal is never for the client to not feel sadness or not to feel loss, because that is normal and that's what we expect. We don't want to suddenly not care that we lost someone who's vitally important to us. We just want to remove the pain attached to it. And so EMDR is really useful in that way because it facilitates movement, and that's what we want to be healthy.
Well, thank you. Someone did write in Douglas College in BC has an end-of-life doula program, so just to
excellent, thank you.
share that. We do have another question, Elizabeth. We still got some time, so not to put you in a hot spot for a long time. but how would you relate the midlife crisis and loss? Could it be attributed to feeling you wasted your youth, meaning 20s and 30s? For example, never really liking your job, not saving money, should have, could have, those kinds of things.
So I think you can experience loss with everything. You know, anything that has been taken from you or you feel like you haven't had any control in, absolutely you can experience loss in. You know, I have seen, I've had clients come to me with experiencing midlife crisis loss, quotations, where it's a period of feeling like they have lost, that they didn't do the things that they felt that they should have, that they felt that something should have happened that never did, and feeling that tremendous loss is really a major variable in terms of being able to cope and being able to focus on moving forward. So I think it's about understanding, where's that coming from? Are they comparing themselves with somebody else in terms of, expectations? It's about understanding, is there something underneath that midlife crisis? Is this a depression? Is there some reason that you're ruminating about this? And of course, we know in depression, a lot of the times we get an idea and it spins and spins and spins and it becomes something altogether different. So is it really a midlife crisis? Is there some sort of organic thing going on? Who's to say? But I think it's really about validating whatever the client is feeling as being real. It's not our role to dismiss things as not being important. And that was really what my goal was in terms of presenting today, to say there's lots of layers with loss, and they're all valid. And I think what we need to do is we need to say to our clients, anything that you're feeling is real. Let's see if we can find a way through it.
Excellent, thank you. Another question, because we still have some time. How do you treat a client with multiple losses who seems to have maybe given up?
Well, that's a tough one for people because I think a lot of the times those are the people that I tend to see in my office. These are people that they have had so many things happen that they just feel overwhelmed and they don't know where to start. And I think what I tend to do is I really start with whatever is most pressing to them. It's about what is the thing that's causing them the most pain, the most suffering right now, and trying to help them alleviate some of those symptoms.
Hey, someone had asked what the name of your previous presentation was, so I've just been looking that up. It's on the NLASW YouTube channel, and it was called Treating Grief Through a Narrative Lens.
Right.
So that's the title if you want to look that up. Okay. Another question in terms of more around your work, Elizabeth. What has been the most difficult loss you've had to treat?
That's a tough one. Okay. It's hard to even rate them because there's so many different types of losses. I've certainly, when I worked in corrections, I had people that ended up coming into and being incarcerated that had tremendous family of origin issues that led to addictions as a way to cope, that led to incarceration, and so multiple layers and very, very difficult, especially when you threw in some psychiatric issues that meant that they were unstable because of everything they had too. That's been tough. I think some of the more challenging ones for me have been the complex trauma losses because you have to be so careful about opening that up. You just don't know what's going to happen when you do. And some people are just so precariously safe that you open up the wrong box and maybe you can have some instability with regards to safety. And of course, safety is the most important piece. So even for me doing EMDR with some of these people, it's really, really scary sometimes opening it up. But you have to start with grounding them first to make sure that they have some resiliency and some coping strategies so that they can stay safe no matter what comes up. But I would say probably it's the complex trauma ones that are most challenging for me.
Okay, I think we've answered all the questions that have come in. You did a stellar job of getting through those questions, so thank you very much for that, Elizabeth. So I guess we're going to clue up the webinar as there are no other questions coming in. And I do want to thank Elizabeth for the stellar presentation and for certainly sharing your knowledge, skills, and expertise with us today and in celebration of Social Work Month 2020. Quite exciting. Certainly, Elizabeth covered a lot of important information pertaining to depression, grief, and loss, how to recognize the impact of transitional losses, and the treatment options and therapeutic approaches, certainly for dealing with these challenging issues. Elizabeth, your passion for this work is inspiring, and I know from the comments coming in, people feel the same way. And having you as a colleague gives me great pride in being part of this wonderful profession. So thank you again for doing this national webinar for us in celebration of Social Work Month. For those who attended 75 minutes or more of the presentation, confirmation of attendance should now be available by clicking the yellow icon at the bottom right of your window. And for social workers in Newfoundland and Labrador, this webinar may be claimed as 1.5 CPE credits under the required category of workshops as per the NLASW CPE policy. And we also encourage everyone to complete the evaluation that will appear in your screen as well. And on that note, again, happy Social Work Month. Thanks for tuning in and have a wonderful day, no matter where you're to, if you're starting your day or moving towards more of the end of your day. So thank you.
I just want to say thank you as well to everybody. Wonderful questions. It's really different when you're doing a webinar and you can't look at people's faces and see if they're nodding. So I'm assuming that we're all nodding on this because these are things that we see in our practice. So hopefully this was useful to you. I want to wish everybody a wonderful Social Work Month. It's a pleasure to be able to present on an area that I feel passionate about. Thank you so much for your time.
Thank you.